Hi, and welcome all of you to the show. I'm Dr. Suresh Sankar. I'm a practicing nephrologist, and I also head clinical affairs at NephroPlus. And we have a very interesting show today. To start with a brief introduction, kidney disease in India affects 1 out of 10 individuals, and the field of nephrology is growing rapidly. We felt it's a good juncture to pause and reflect where we are. And to this effect, NephroPlus is happy to bring you a show titled REABSORB, where we look at the history of nephrology with conversations with people who actually created it. Very happy to welcome Professor Chacko Korula Jacob to the show. Welcome, sir.
Thank you, Suresh. Thank you for having me as the first.
It's a true pleasure. Dr. Jacob may not remember me when I first met him. It was 2000, 2001.
With Georgie.
Yes. And what he always strikes to all of us is the humaneness, I think the humility, and also the humor. I really have admired him with somebody who is on a chill pill, very, always very enduring whenever I've engaged with him. To the audience, to introduce Dr. Jacob, he spent the last 5 decades of his life in nephrology. Started his career with his MBBS in 1970 at Christian Medical College, Vellore. Followed up with MD General Medicine in the same institution before completing his nephrology training in 1980 at CMC. Subsequently, Dr. Jacob went on to have a stint abroad at the University of Alberta as a senior resident and subsequently as a fellow of the National Kidney Foundation of Canada. Dr. Jacob subsequently spent 3 years at Queen Elizabeth Hospital, Adelaide, before returning to CMC. There, he rose through the ranks to head the department as a professor and head. And in those days, I'm talking in the 80s through until his retirement, he trained and mentored 40 nephrologists, which is no small task. And to his credit, he's got more than 100 publications and has had 5 chapters in peer-reviewed journals. It's stupendous that he was part of a team which successfully led 3,000 kidney transplants, both living and deceased donor. He's extremely well respected in the professional community of nephrologists. He was the past president of the Indian Society of Nephrology. Also received a lifetime award from the Indian Society of Nephrology. He's had numerous orations and invited speaker in pretty much every nephrology conference you could think of. And I should tell the audience that this is a very brief introduction. With that, Dr. Jacob, any opening comments before we kind of jump into your memory lane?
Yeah, I think first and foremost, Suresh, thank you very much for those kind words of introduction. I have actually particularly been interested in this history in the recent past.
Okay.
Because I've in fact made a document of the history of development of nephrology at CMC Vellore. And
oh, wow!
And
is it on print or is it on a digital medium?
No. It's. I've just sent it to the department for the local people in-house to edit and add a few photographs and all that, and ultimately hope to bring it out as a little booklet kind of thing. Yeah.
I think we should have you on the show another time for the launch, the digital launch of the book.
Yeah, and
looking forward to it.
I just start with a quotation which says that the generation that ignores history has neither a past nor a future. This is a Canadian philosopher, and I think as you grow older, I think you tend to have a sense about what's been happening. So I'm really happy, very happy to be here with you this evening.
Fantastic. I personally am a big fan of history. I think there's very rich lessons if you have an open mind to reflect and learn. So, having said that, I think let me start. Let me take you back to where it all started. Like, when was it the word of nephrology actually crossed your mind? I mean, as an undergraduate, or
Well, we really didn't have much exposure to nephrology as undergraduate students, though, I joined for my MBBS in 1963, and Vellore had done the
I
first.
wasn't born then.
Pardon?
I wasn't born then. Yeah.
Yeah, and CMC had just done the first hemodialysis in the country a year earlier, so 62. So, so we were, sort of there from the beginning. And but as I said, as undergraduates, we had very little exposure to nephrology. There was, I mean, we were posted in one of the medical units, general medical units, which was handling nephrology services at that time. And this was under Professor P. Koshi, the one who actually started the hemodialysis program. Uh, and then on completion of my MBBS, I went and did 2 years as a tutor in biochemistry, teaching
Hmm.
teaching undergraduate students biochemistry. And I was terribly interested in the subject. In fact, I wanted to do an MD in biochemistry and then a PhD. And then in those days, you then went to the US and did a postdoctoral, and most of them stayed on there. That was the kind of
Hmm.
career in the pattern in those days. But two things. One is that the biochemists, the non-medical biochemists were really not very encouraging of medical people taking up biochemistry in those days.
Okay.
Uh, yeah. It was sort of tough protection that they had.
Okay.
And the second was that I ran into a professor of medicine of mine, and he said, "What are you doing next year?" And I said, "I'm doing biochemistry." And he said, "No, nothing doing. You come and apply for general medicine." So he actually took me to his office and made me write out an application. See, in those days, there were no entrance tests or NEET or anything of
Math.
that. Yeah.
Okay. Hmm.
Yes, I wrote a letter to the principal saying, "Please change my subject from biochemistry to medicine," and that was it. So,
That is destiny. Biochemistry's lost, nephrology's gained.
no, actually, no, there is a lot of thing because in my second posting as a postgraduate in medicine was in nephrology, and I
Okay.
found that was one particular specialty where there was a lot of chemistry involved. Actually,
Hmm.
application of what I had learned in biochemistry. And
Hmm.
also, at that time, one of the faculty in the department, there were only two faculty members in nephrology at that time, and one of them decided to take a long time off, about 3 or 4 months. He was going away. So my posting in nephrology got extended from 3 months to
As,
6 months.
during your residency, you're doing a postgraduate MD program.
Yeah, and so
Okay.
then I kind of liked the subject, and then so after completion of my MD, I applied and got in, and
One went.
that's the whole thing started. Yeah.
Yeah. So destiny again. So it was leading you to nephrology. So you wouldn't have gone anywhere else. Was it kind of difficult as you kind of stepped into the field, because it was in the realm of unknown, right? You didn't have a department. It was just
So
evolving.
actually, that way, I think CMC was very forward thinking because as early as 1971, Dr. P. Kochi decided that, if nephrology has to develop, it should be hived off from medicine. So he actually started he gave up the nephrology part, and that's how Dr. K.V. Johnny became the head of nephrology, and Dr. Koshi continued as the professor of medicine. So, so it,
You had some true visionaries then who recognized
yeah. So
the
back
need.
as early as 71, we had a separate department. And
Was okay. Was
but
it among the first? Or I mean, I suppose PGI was there before that, right?
PGI actually, I think, yes, had a separate department, but they still continued to handle a lot of general medicine
Okay.
like that. Whereas here it was exclusively nephrology. We did not have to do any
Any
handle,
medicine.
take
That,
call for general medicine or anything of that sort.
and how big was it when it
It was
started?
a very small department. There were two faculty members, Dr. Johnny and Dr. Shastri,
Mm-hmm.
and and then four senior house surgeons and the rotating medical postgraduate. Yeah.
Got it. Got it.
The
But
dialysis unit was a four-bedded dialysis unit with very primitive,
I
what
can
now
imagine the
primitive
technical.
equipment. Yeah, we in fact had to prepare dialysate fresh every day in a big aluminum vat, stainless steel vat, and then that used to flow down by gravity into the keel dialyzers, and the only access we had were Scribner shunts. And if you
Did you
wanted
used to
more,
do them? Did you used to do them
I
with
used to
train,
do
right?
them
Yeah, that's
also.
what. Yeah. I've seen that in.
And if you wanted more ultrafiltration, you drop the drain tube lower and lower down to give more negative pressure. So that's how we started. But then in 76, we got the multi-patient proportionating units from Drake Willock, and that was a big
Quantum
thing.
leap.
Yeah, because from then on, you really didn't have to prepare fresh dialysate every day. You could get the concentrate, and that would thing.
That would.
Yeah, and then of course, very soon after that, the single patient units started coming, the Cobes entry machines and various other machines. Many of those companies are no longer existent now,
Do,
actually.
do we look forward to pictures of these in your book on the history? It'll be.
There are photographs of the old machines, the old keel dialyzers, even
Mm,
the first Travenol twin coil machine which we had, which started hemodialysis with, yeah, all those things are
mm.
there.
Oh, okay. So we'll look forward to your book. I would like to hear your stint abroad. I'm sure in those years, with lack of communication, and I'm sure it was very far from home, being in Canada and Adelaide. What were
Yeah.
your reflections on those?
Canada was the first. The reason I went to Canada was because on completion of my 2 years of training as a DM candidate, when application went in for sitting for the exams, they said I was not eligible to appear because there was no recognized teacher because Dr. Johnny had left the institution by then. So
Hmm.
here, having done 2 years of training and no possibility of taking the qualification. So I quickly wrote off to the same center where Dr. Johnny had gone, which was the University of Alberta. I just
Oh,
wrote,
okay.
yeah, but I wrote to the boss there, the director there, person called John Dossiter, who was very welcoming. He said, please come and join. And so in 78 January, I went. I left Vellore 78 January and landed in Edmonton with a temperature of minus 40 degrees Celsius, and it remained like that.
Cool.
Remained like that for the first 3 or 4 weeks. Yeah, and it was kind of difficult because my wife and our 4 month old son had to stay back because she was still completing her
Hmm.
graduate
Hmm.
training, and letters would take 2 to 3 weeks.
I was about to ask, how do you
Yeah,
communicate it?
and if you
Because
made it, I mean, if you tried to make a call, you had to book a call and wait half a day to get across. So it was kind of
and,
difficult. And
and you had to yell across the phone to for the other person to hear, right? I'm familiar with that, and the 2 minute call, and it
yeah,
gets
and
disconnected.
unfortunately for me, I also developed a PUO at that time, and which went on and on and on, and then ultimately I had to have a gallium scan which picked up mediastinal lymphadenopathy. So I implemented
Wow,
a mediastinoscopy, which is
wow,
unheard of. We had not heard of those things. And that picked up TB, and then I had to have anti-TB treatment. So it's a long story.
oh
But
my God.
at the end of
Hmm.
18 months, uh, I did as a clinical senior resident, and we were on call every day. for that 18 months, except on alternate weekends. Weekends used to start on Friday night, and you are off Friday night till Monday morning.
Right.
But 18 months of on call every day, except alternate weekends. So at
Mm-hmm.
the end of that, by the time my wife and son had joined me after a year, but at the end of 18 months, I applied for a National Kidney Foundation fellowship. Main reason was that I wanted to get some laboratory experience,
Got
because
it.
that unit had an excellent transplant immunology lab, and so I worked on, actually, surprisingly, a thing which was the hot topic in those days. I set up a method for analysis to measure circulating immune complexes and their clearance by the reticuloendothelial system. So,
Wow.
so
Hmm. How long
I
did you work in the lab that time?
1 year, one
Okay.
year. I did a year and just set up the technique, and then I left, because by the time Vellore was calling saying that they were desperate for people, so we came back actually, and that's the.
Okay. And I mean, I'm sure those days the north-south divide was really wide, unlike now, right? I mean, now a lot of things come to India as soon as or very early after things come up in the West. Then
Yeah.
when was in your CV you mentioned about spending time in Adelaide. How was that? Was
That
it
was a bit later. That was from 85 to 88.
okay?
So
You
came
went.
back from
Hmm.
Canada, worked for 5 years, and then went to Adelaide for 3 years.
And like when I went to med school, I'm talking in the 80s, early 90s. Academic medicine always had your teachers who were intense, passionate, and disciplinarians. How was it for you in nephrology?
Oh, but not only in nephrology, I think even in medicine, we had very, excellent clinicians, because very few laboratory support was very minimal in those days.
Diagnostic tests, yeah.
So most of the things were actually clean. Dr. P. Koshi, for example, used to stand at the foot end of a bed and watch the patient's head shaking and say, "This chap has got dominant aortic regurgitation," just the way the fellow's head nodded, or picking up signs and making clinical diagnosis was the in thing.
The vanishing trait in medicine these days,
Yes, yes.
bedside examination
Yeah,
and
yeah, bedside examination is, and they were totally dedicated. They were all full timers, so there was no question of full time faculty at the hospital, and their commitment to teaching was exceptional. I think so.
were there taskmasters, hard taskmasters?
Uh, I don't think so. I mean, I think we're different.
You must have been a very tolerant and open-minded learner.
No, I don't think there's any compromise on patient care or this thing,
Hmm.
uh, no, I don't think they. I mean, they pushed us hard because
Hmm.
so much had to be done, and but they were also nice people. I don't think there was anybody who was particularly nasty or thing.
Okay. So how is it your colleagues and the people around you, maybe the nurses, technicians,
Yeah.
doctors, okay, how is that experience?
When,
Because
when I joined in nephrology, as I said, it was a very small department. Dr. Johnny had left by 78. So there was Dr. Shastri and Dr. Kirubakaran. Mesha Kirubakaran was a year ahead of me throughout.
Mhm.
There was only the three of us on faculty at that time. And of course, the postgraduate training program had started by then.
Oh,
The
okay.
Yeah. Initially, see, the DM program had to be stopped when Dr. Johnny left. So
Left.
for
Because
several years they did that. That did not start. But we had the predecessor of the national board. It was called the Academy of
M&Ms.
MNAMS. So
Correct.
MNAMS training had started. CMT and Tirupara Sundari from the railways, Dr. Anuradha, Dr. Deshpande. They were all some of our earlier
Okay.
trainees who
Mm-hmm.
joined us.
Mm.
So, so faculty-wise, there were only three or four of us, but we had the trainees, and then uh, the
Life must have been pretty busy for you, all of you, with.
oh, yeah, yeah. It was
Mhm.
very, very difficult because I think during the 2 years of the training program, Dr. Kirbakaran and I were on call every day because one had to cover the general ward patients and the other had to cover the private ward patients. And if we wanted to go out for a movie or a dinner or something, we had to sign out to the other person. And there was no way that both of us could go at the
Would
same
go
time.
out. So I think you really needed a very understanding and accommodative colleague to
Yeah,
even
we
live
had
the
to.
life.
I mean, there was no choice. I
Right.
mean, you had to because I mean, people have to take leave now and then, and unless you are accommodating, it just doesn't work. The very early on, I think Meshach recognized the fact that that is the time the nurses started getting recruited to the Middle East. There was a big
Mm-hmm.
away. So
Mm.
he realized that we are going to run short of trained nurses. And so he started the technician training
I
program.
was about to ask that. How did you build capacity beyond doctors? Okay, so you started what was it a bachelor's program or how
No,
was
no,
it?
no. It was a
Was it?
1 year in-house training for
Mhm.
science graduate. Any science graduate would be given in-house training for a year on.
Okay, a college graduate, a science college graduate. You're
Yeah,
talking.
they had to
Wow.
have a science
Mhm.
science.
That's amazing. Hmm.
And we had some exceptional technique, what we used to call technicians. I think they prefer to be called dialysis therapists these days, but whatever it is.
Uh-huh. Mm-hmm.
And the staff was always a mixture of the two, predominantly the technical or the therapists and a scattering of nurses, because nurses were a difficult commodity at that time.
Okay. Did the infrastructure and technology start changing through the 80s? I mean,
Yeah, sure. I think in '76, they built a new dialysis unit. Uh, See, as I told you, when we started, we had only this 4-bedded. Then this became a 20-bedded dialysis unit, and we started initially the multi-patient uh, units, and then the single patient unit started coming, and we got our first RO plant uh, in probably somewhere in 82, 83, I think. That came under a US aid grant, actually. So for the first time, we were using good quality water, and obviously the survival and quality of life of patients improved. Then by the mid 1880s, the disposable dialyzers became available. So till then,
80s. Okay. Mm-hmm.
we were using the keel boards, which you had to
Mm-hmm.
build each time and see. So, and then of course, things started improving, but at the same time, the patient load also increased, and the
You must have been ahead of Chennai and pretty much most of the centers in the south, right? With technology and the services offered,
yeah, 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 yeah.
pretty much. Yeah. Because yeah, so what was it? I probably should shift into another part of your work. We all know that time and space influence disease patterns. So what is that you are seeing in terms of
Oh,
disease?
yeah. I think the spectrum of diseases has changed completely. I think, when we were training and in the early days, if you
Mm.
walk if you walked into the ward, there'd be at least three or four patients with a post-streptococcal glomerulonephritis. Most often kids with the impetiginized scabies and then getting a sting or a sore throat and post-streptococcal GN. You could easily find two or three patients in the ward. Septic abortion and cortical neck.
Obstetric nephrology was a big one. I know
Yeah,
I've read some of Dr. Chug's papers on trends in obstetric
yeah. So, and diabetic nephropathy was a very small segment of our patient load.
CKD. And what about acute kidney injuries? What kind of ones were you seeing?
Pretty much mostly snake bite, cholera. Cholera
Mm-hmm.
is very common. Cholera and
Mm-hmm.
snake bite, two common ones. And then, of course, suicidal attempts and poisonings. With
A lot from rural parts.
way in early 80s, we identified a lady who had taken Aristolochia indica as a
Mm.
suicidal agent, and she developed acute kidney injury. We got the botanists in the local college to identify the plant, and then we wrote it up and sent it to the American journals, and they
Mm-hmm.
refused to accept it, saying that we had to do animal experiments and prove that it was.
As always, the bias was there. So,
And we used to have very rare, unusual things like goldsmiths coming with exposure to mercury and membrane,
Mercury, I was about to think.
mercury, gold, and remember. So all kinds of things which I don't think the present generation are seeing. Actually.
As tropical nephrology, as we
Lupus,
used to read it.
lupus
Uh,
was there. I mean, always lupus
mm,
was. But the
mm.
other vasculitic things, ANCA and things were unknown in those days, so we had no idea of identifying.
You must not have had access to diagnostic tests to identify them too, right? In the 80s.
The labs, for what was available in the rest of the country, I think the labs were very, very high tech. I think we were very particularly good both biochemistry and microbiology support. So that was excellent. And pathology, I mean, Dr. Anand Date,
Mm.
most of you would have heard, was a
Mm.
dedicated nepropathologist, and
Yeah,
he would uh, always give us a report within 24 hours of doing a biopsy. He would give us a,
amazing.
yeah.
That's amazing. So,
And
so how was it in terms of doing a kidney biopsy? I mean, that is an interesting story too.
don't even,
For present day nephrologists to actually.
we used to do a KUB film, measure the lateral border of the left, usually the left kidney below the 12th rib, mark that spot, and then we had what was called the Franklin's modification of the Wim Silverman needle. The
Mhm.
Silverman was the long needle for the
Yeah,
liver.
I've seen that in the
Yeah,
nephrology.
this is a shorter one,
Mm-hmm.
and then it was double blind. Patient is blind,
Okay.
double blind, hit, and but we used to get excellent cores. You get very
Of
nice
course, the
thick
chunk.
cores with that.
Mm-hmm.
But at the same time, we used to get all kinds of unwanted tissue, fibrous tissue, spleen, liver, all muscle,
What was
and
your success rate? I mean, if you had to kind of
that's
put a number to it.
we used to get more than about close to 90%.
That's
Despite that.
pretty good. I mean, that's still pretty good when you
And then
what we.
then the next improvement was when we said patients with normal kidney function, we used to do a 1 minute urogram, give one small
Hmm.
amount of contrast and take a single film at 1 minute, and then use that to measure the more accurately locate the lateral border.
Yeah, for your glomerulonephritis and all of
Yeah,
those.
and then of course, then ultrasounds came, and then it became a laugh after that doing a biopsy.
Yeah, yeah. Now, and of course, your central lines were all blinded and just
Yeah,
like this,
I
right?
mean, the dialysis catheters were unheard of in those days. We were all, I mean, early days, which was all the Scribner shunts, which we had
Fibrillation. Hmm.
then. And then came the single lumen femoral, then putting the double lumen catheters came, and then started doing subclavians, but they had a very high incidence of subclavian stenosis, patients who developed stenosis. So we had to, and then of course the
So you kind of
non-tunneled IJ and then the tunneled IJ.
tunneled IJ. The tunneled IJ is yeah, so much. So you kind of seen it all from nothing to so much in your own career. Um, Now, how is it in terms of building your teaching program? How in terms of attracting young doctors to come into the field? Because you, from being a novice, and you entered CMC, and as you climbed up.
Yeah, I think CMC always being a teaching institution, teaching is, I mean, I think the department has three pillars. One is patient care, the other is teaching, and third is research. And I think, you have to have the faculty has to be ideally a blend of all three. There are, of course, people who are predominantly more interested in research. There are some people who are predominantly clinical care, and then there's, see, so there, but generally everybody, all the faculty are involved in all three. We had a very well organized teaching program set up, even when I joined for Westing, for example.
How big was the program in the 80s before? When
80s, we had only about two or three postgraduates at
Okay.
the time. Yeah.
Okay.
Yeah, there used to be two. So, and it was a 2-year program. So four trainees, but we had a journal club every week, and we had a lecture every week. And of course, bedside teaching goes on all day, every day.
All day, every day. And it'd be interesting to listen to some of the research projects that I for one remember when I was doing the nephrology in the 90s. I remember the wonderful paper on the timetable of infections after kidney transplant in India. Something that was CMC valued. When I finished my training, I do not know.
Yeah, I think George T. John published that. Yeah,
but yeah. Going back to your own times, your research projects and collaborations. What stands out?
I think very early on we realized that basic research is not, we don't have the funds or the faculty or the time to be involved in basic research. So all the research has mostly been clinical oriented research. Lot of it was towards because transplant was a major part of our workload, and so we were looking at mainly how to minimize the cost of immunosuppression and the total immunosuppressive load, both, to balance the two. And towards that, I think we have published papers on ketoconazole augmenting levels of cyclosporin, as well as ketoconazole augmenting the levels of sirolimus, which was known as rapamycin in those days. And and then later on, things like use of leflunomide for CMV, and so various clinically applicable things.
Local solutions for the Indian context and
That's right. And I think because we also found that the major cause of one of the major causes of mortality in the morbidity and mortality in the transplant population was infections, and this probably directly related to the immunosuppressive load. The whole concept of therapeutic drug monitoring and to came in. And in fact, we were very fortunate to have two clinical pharmacologists who were interested in doing therapeutic drug levels, but they didn't have the funds. Whereas nephrology at that time had reasonable amount of funding, so we actually funded the clinical pharmacology lab to a large extent to get their equipment, and then they started doing, even all the not only the CNI assays but also mycophenolate assay, which very few.
Yeah, I know. I've read about this.
Do. Yeah, and even leflunomide, all these things are measured in the clinical pharmacology lab, which was largely funded by nephrology. The other thing was that we also found that rapid diagnosis of CMV and other infections, the main labs were not able to handle that. They took time. So, with the permission of the with the permission of the administration, we set up a immunodiagnostic laboratory as part of the nephrology department, and had a PhD virology person in charge of that. And
Hmm.
that person also then, over a period of time, switched to doing uh, relationship, kinship testing, uh,
Hmm.
establish kinship, doing mitochondrial relationships and all that. So these are things which we were able to.
So you actually, I think a lot of your passion was around transplants. So you've always, right?
I think, yeah, but at that time it was around transplants. I don't know what the focus these days is. I think
No, no, but I'm saying,
it is
it was a
CAPD.
very, I'm sure it was very challenging, and I think a lot of knowledge has come out of CMC for us in nephrology in India. If I were to ask your high point in your career, some high points, I'm sure we have highs
I
and lows.
think, yeah,
What there is a few moments that you say, I really cherish this. If I had to pick your brain.
the high points really is to see the former trainees doing very well in wherever they are placed. I think
Mm-hmm.
we have several people heading units in Australia, in US. Hari trained with part of his training with us, Hariharan.
Mm-hmm.
Then
Yes.
then in Australia, there are three or four units ahead. And so seeing them doing well is really one of
I,
the most
I
rewarding.
do recall a conversation that you mentioned. You may not remember. You said, if I travel in Australia, I just don't visit cities. I just hop from one place to another where my students are. I just visit students and I'm done with my Australia trip.
Yeah.
Is I think you have one in every big city in Australia, I'm sure.
In fact, in 2000, yeah, so about 10 years ago, they did organize a all Australia tour for my wife and me.
CMC alumni.
Yeah, we reached Australia, but within the travel within the country was organized by them. So it was really, see. And the other thing was, I think, being invited to give a podium lecture at the World Congress in Berlin when they asked me to
Hmm.
talk on
And you
dialysis
talk.
in developing countries, and also I
Which
had
year was this? Was this 2000? 2000?
for the year now
2000. Just sometime in I remember. I think it was late 90s, 2000.
Berlin,
Yeah. Hmm.
and. So I had to write around and get information from all our neighboring countries because it was in developing countries,
Developing countries.
not in India. But
Hmm. Hmm.
uh, so that was one, and then was also signing the twinning program with the Manchester Royal Infirmary as part of the ISN
ISN Sister Center program. Okay.
center
Which
program.
year was that? I mean, because the Sister Center program was more after 2000, right? When John Dirks was there at the helm,
Yeah,
right?
John Dirks was the moving spirit behind that. Yeah.
Mm-hmm. And you worked with.
I still have the photograph with John Dirks, Barry Brenner, and Robert Schreier handing
Mm.
handing over memoranda of understanding.
Where was this? I mean, was it in one
In
of the?
one of the meetings, I don't remember which meeting actually.
Okay, but it's epic that you had Bob Shire, I mean Shire and Brenner in the same stage
But
from
I'm glad to see that John Dirks is still very active. I think he's still
even these days.
John Dirks is still active. I saw him at a program recently, actually.
Mm-hmm. Oh yeah, I mean I know when I was the secretary for the Southern chapter. This is 2009 to 13. Dr. Dirks used to visit for all our meetings. Extremely dynamic person, no doubt. Um, would you recall any challenging phases? Like it's really rough and tough during this 5 decades.
I think the most challenging part was when I when I realized that at the end of 2 years I couldn't take the exam.
That was that. No, that must have been a heartbreak.
That was a low, yeah, because I kind of felt cheated actually, saying that look, these guys have advertised for a training program which is non-existent.
But then I guess that was when you went moved to Canada, and then
Yeah. I think
that
things were,
nullified this.
yeah. But that certainly was a very, I mean, was not something that I expected at all, I must say.
That was just administrative rules that disrupted.
Well, that's the university thing. I mean, I
Exactly.
don't
The
think anybody
universities.
done anything about it, but it's difficult when you're at the receiving end
Correct.
of it.
Exactly. I can imagine. You put in the you pretty much lived all your years at CMC in the nephrology ward and say that you're not trained enough. Then, too, as we sort of come to the end of the show, where do you see nephrology going, particularly in the Indian context? If you have such an overarching view of the field, where do you see it going?
So I think there are plenty of training positions now open.
Mm-hmm.
So I think every year the numbers of nephrologists coming out is quite large, and as you probably realize, I think all the tier one cities are saturated already with
Correct.
nephrology.
Absolutely.
People,
Absolutely.
so people have to move out to tier two cities, uh, which is good. But my what worries me is when I follow some of these WhatsApp groups, like the transplant group and various others. I don't make too many comments on those. I just keep
You're a
following.
silent spectator.
Well, not really silent. When I really feel riled, I reply. But otherwise,
I'm very silent on those groups. I mean, I do throw in a query when so it's a
no,
patient.
really, what worries me is the fact that people are more. Yeah, I mean, everybody needs money. I'm not saying that you don't need money or that that you should not be uh, compensated for what you put in. But when that appears to be the driving force, I think that's a bit worrying. Taking on sort of borderline donors, going on extending the more and more iffy donors, and that leaves a very worrying thought
You know,
and
I, I you
not
know,
a
I,
very.
I partly agree that the fact that it's the field of medicine and healthcare has become very transactional, and yeah, there are multiple reasons, I guess. No, I share your sentiments on this, definitely. Anything else that you feel, other than these kind of values of people and um,
No,
other.
other than that, I think it's still attracting bright kids, I think,
Mm-hmm.
uh, uh, who are quite hardworking. I have a kind of attachment with the Manipal group here in Bangalore.
Mm-hmm.
Uh, I used, I used to go once a month and do a bedside teaching, but now it's become less frequent and only nearer the exam I would get to meet them. But I
Mm.
find they're a very hardworking group of youngsters and enthusiastic to learn. So it's good. I'm happy that.
It's amazing that you kind of are daring to travel in Bangalore from one place to another with all the traffic there.
Oh no, it's only once on a Saturday morning. I go for a couple of hours, and it's actually when I moved to Bangalore in 2009. Right from then, Dr. Balal asked me to join them
Mm,
on
mm,
teaching teaching
mm.
program, and I quite enjoy doing that. So.
I'm sure you wouldn't feel complete unless you have student engagement from the way you lived your life,
And
right?
I also still see patients by prior appointment in a very small trust hospital very close
Baptist,
to my. Yeah,
Baptist,
no,
right?
no, no, I left Baptist
Okay.
some years
Mm,
ago. There's a
mm-hmm,
Mudaliar Trust Hospital, uh,
mm-hmm.
10
Closer.
minutes home. Yeah, very close to home.
Mm,
But I don't go and sit there. The patients call and then the hospital calls me and I give them a time and thing. And
mm-hmm.
it's nice because, I have patients whom I've treated in, tell you a chap who landed up from the Middle East, who 1976, when I was doing my first year DM, he came with a he came
That is unbelievable.
he came with a IVC thrombosis and membranous nephropathy because the renal veins were thrombosed, and we
Okay.
put him on anticoagulants, and he's still taking Ecosprin 75 milligrams a day now, and his creatinine is 1 and his proteinuria is gone. So he tracked me down and
Oh
came
my
all the way
God.
from
Uh,
Abu Dhabi to see me.
that's a very interesting anecdote. So no, I think I suppose the patients in the trust do not know, whom they're seeing. I mean, with such
Yeah.
a, you're
And,
so inconspicuous and very humble as you walk in there. That's
few,
very.
few of the old Bangladeshi patients also turn up from time to time to just
Mm.
say.
So, so,
So
so we don't see you on social media as to where you are and what you are. So we let it known. We let known where people can find Dr. Chacko Jacob after the show. So I think that kind of brings to the end of the show, Dr. Jacob. It
thank
was
you very
truly
much.
a pleasure and honor to have this conversation over the last 30 minutes. And to our audience, I think this is the beginning of several more conversations that we're going to have. You can find us on YouTube and on our social media links. And any feedback, please write to us contact us at NephroPlus.com. And thank you very much. So I think, sir, it is very nice. So they'll edit it from here.
Yeah.
It's very nice, wonderful. I really think I enjoyed it, and there's no way I got half an hour of storytelling like what we have. No, it's amazing. This is off the record. I'm sure it's getting recorded. They'll edit it.
Yeah.
2013, Jayant and I were traveling back after the ISN meeting, Southern chapter meeting at Pondi. And I was telling Jayant at that time, Jayant, we should do a history of nephrology. That's when the International Society of Nephrology had this history of nephrology series with short videos and everything. So I was telling Jayant, we should do this. This is 2009, 10. Oh, was it 12? So somewhere. And then it just never, I said, we should put it together, a bunch of other things. Never happened. And then this opportunity came, so, when we said we should do something. I said, history of nephrology. I grabbed it so I can talk to all of them.
So if my former colleagues in the department ever get their act together and bring out this booklet, I'm sure you get I'll make sure you get a copy.
No, we will have you on the show. I want to add pictures to the conversation. I think that's kind of my own wish. Thank you, sir. Thank you very much.